Então, bom dia a todos, pessoal. Agora, a reunião de hoje vai ter o tema de microscopia confocal em óptica cirúrgica. Teremos a participação do Dr. Pedram Hamrah, de Tufts University, Boston. É um prazer tê-lo conosco e, em virtude da participação dos nossos convidados, essa reunião será em inglês, ok? So, welcome everyone to our weekly surgical optics meeting. Today we have the honor to have with us Dr. Pedram Hamrah from Tufts University that will present his experience in confocal microscopy and dry eye after refractive surgery. We'll start this meeting with fellow Marilia that will present us a published paper. Okay, so Marilia, please go ahead.
So good morning, everyone. I'm gonna present a scientific paper, and it's a post-LASIK ectasia versus keratoconus, an in vivo confocal microscopy study. The first author is from Iran, and it was published in the Journal of Cornea and External Disease last month. So the authors have no funding or conflicts of interest to disclose. And so concerning the purpose of this study, the author wants to know if there's any difference in the characteristics of corneal, cellular, and subbasal nerve in post-LASIK ectasia corneas, normal post-LASIK corneas, keratoconus, and normal corneas. So it was a cross-sectional comparative study held in Iran. They examined 97 eyes of 87 patients between 18 and 45 years old. And the exclusion criteria was history of contact lens wear, previous ocular surgery, trauma, corneal scars, corneal pathologies, diabetes, systemic autoimmune disease, and any finding indicative of preoperative keratoconus. They were divided into 4 groups, 18 eyes with post-LASIK ectasia, and the ectasia was considered when there was progression of the myopia, decrease of the visual acuity, or topographic evidence of progressive central or paracentral steepening. Also 18 eyes post-LASIK control group, 18 eyes with keratoconus, which was diagnosed when there was central or paracentral corneal thinning, conical bunging, Fleischer ring, or Vogt striae, and keratoconus signs on corneal tomography, and 29 normal corneal eyes. They were all submitted to complete ophthalmological exam and also to in vivo corneal confocal microscopy with the Heidelberg retinal tomography laser scanning with the Rostock corneal model, which provides high contrast, accuracy, and quality images from all corneal layers with 800-fold magnification. And they took 2 frames from the basal cell, basal epithelial cell, the anterior keratocyte and posterior, and also the endothelium. And the analysis of the subbasal nerve was made with an automated software. So the main parameters that were evaluated were the nerve fiber density, the nerve branch density, the nerve fiber length, the total branch density, and the nerve fiber area, and the nerve fiber width. So for the results, here we have the demographic and ophthalmic data at the time of recruitment, and the full preoperative medical records were not available for 8 patients in the post-LASIK ectasia. And we can see that there was no difference between the KC and the normal corneal groups for age and gender, or between the post-LASIK ectasia and post-LASIK control groups for age distribution. However, there were more women on the the post-LASIK control group compared with the ectasia group. And the mean time since surgery was 14 years in both groups, and the mean attempted correction was 3.49 in the post-LASIK ectasia group and minus 4.26 in the control group. So concerning the subbasal nerves, we have some images of the subbasal nerves, and we can see that there was more deviation from the vertical orientation in the post-LASIK ectasia than the control group, and it was most pronounced in patients with keratoconus. Also, there was a decrease in the subbasal nerve density in the post-LASIK ectasia groups and in the keratoconus compared with the control groups. And also that the subbasal nerves were pale in 25% of cases of both post-LASIK groups. Also, the presence of microneuroma seen in this black arrow and the nerve loss in the white arrow was unique to the keratoconus group and observed in 31% of the patients. So here we have the findings based on univariate analysis of variance, and we can see that the mean endothelial cell density did not have significant difference among the 4 groups. The mean basal epithelial density was lower in the KC group compared with the normal corneal group, but the difference with the post-LASIK ectasia and post-LASIK control groups were not significant. Both anterior and posterior keratocyte densities were significantly lower in the post-LASIK ectasia, but in the post-LASIK ectasia and the post-LASIK control and the keratoconus group compared with the normal corneal group. The nerve fiber density, the nerve branch density, the nerve fiber length, and nerve fiber area were lower in the KC and the ectasia groups. And total branch density was lower in the KC group compared with the normal corneal group, but there was no significant difference between the post-LASIK control and normal corneal groups regarding these parameters. And here we have the pairwise comparison of cellular and subbasal nerves parameters. And we see that the mean basal epithelial cells density was lower in the KC group compared to the normal corneas. But the difference in the post-LASIK ectasia and post-LASIK control group were not significant. And the comparisons between the post-LASIK ectasia and control group did not show any significant difference for any of the cellular density variables. However, the ectasia group had lower nerve branch density, nerve fiber length, total branch density, and nerve fiber area compared with the post-LASIK control group. And comparisons between the post-LASIK ectasia and KC group showed higher basal epithelial cells density and lower anterior and posterior keratocyte densities in the ectasia group. And there was no difference regarding other cellular or subbasal nerves parameters. Here in these pictures, we can see that there is a decrease in the basal epithelial cell density in the keratoconus group, which has already been described in other studies. And for the conclusion, The author says that the result shows that the cellular properties of post-LASIK ectasia may be different from what is typically seen in KC, and that changes in the basal epithelial cells and anterior and posterior keratocytes seems to have no role in the development of post-LASIK ectasia, and that the subbasal nerves seem to be involved in both conditions. For the discussion concerning the subbasal nerves, that it was found to be affected in both post-LASIK ectasia group and keratoconus. So far, we don't know their role in the process of keratoconus, so little can we know about its responsibility concerning post-LASIK ectasia. And can we infer that it affects the post-LASIK ectasia corneas the same way? And can we compare the physiopathology of the keratoconus with the post-LASIK ectasia, considering that the KC is a degenerative process and the ectasia is most probably a mechanical condition? And that's it. Sorry, thank you.
Thank you, Marilia, for your excellent presentation. And I'd like to thank once again the presence of Dr. Pedram Hamrah. He's now assistant professor of Tufts University. He has an extensive research line in confocal microscopy and corneal nerve alterations, and has excellent articles published all along his career. And I thank you once again for the participation, and I'd like to ask if you could comment on this article. Did you know it? And do you find these questions that we raised relevant? And do you have an answer for any of those? But before, Dr. Paula asked for some words. So Dr. Paula?
Dr. Hamrah, thank you so much to be here. I know you have all-day clinic on Fridays. I'm going to introduce Dr. Hamrah. He did his medical school in Germany. He's now director of the Center for Translational Ocular Immunology at Tufts University. And he used to work at Harvard too. And I had the opportunity to follow him in clinic and also in the lab he coordinates. So thank you, Dr. Hamrah. And if you can comment the article, please. And then you can start your lecture as well.
Sure. First of all, I would thank everyone for inviting me to speak today, especially Dr. Lioretti and Paula as well. I'd seen the article before. It's an interesting article with interesting comparison groups. I think there's the pathophysiology seems to be different between keratoconus and post-LASIK ectasia, the way at least the literature is developing. As you mentioned, it seems to be that for the post-LASIK ectasia is mechanical due to thinning of the cornea during the LASIK or PRK procedures, versus with the keratoconus, there seems to be a mechanical process involved that results in nowadays thought to be inflammation. And the inflammation results then in the loss of the collagen fibers and also the nerve loss that you showed in both. Now, what was interesting is that the nerve changes are kind of similar between the post-LASIK ectasia and the keratoconus, but the post-LASIK ectasia show also less nerves than the control groups. And that could also be explained by the fact that because of the thinner cornea, as we ablate deeper into the tissue and actually ablate more nerves than we would ablate in the control groups where the cornea are less thin, it's hard to say without having a longitudinal study whether the nerves develop differently, and that's important to understand. So I think to be able to connect the nerves to some of the pathophysiology, we need some longitudinal studies to see if the nerves are developing differently, meaning do they come back and do they regress? Do they not develop at all because of the ablation? Do we have less nerves after the ablation? And so these factors are very important prior to drawing any definitive conclusion. But in my opinion, at least because of the deeper ablation, you just ablate more of the stromal nerves and the recovery of the nerves will be hampered. Now, whether that is directly involved with ectasia or not, it's difficult to determine, as I mentioned. But the damage in nerves has been shown to result in significant cellular changes in the cornea, particularly in the epithelium, which the post-ectasia cases did not show in this case. So those are my thoughts about these cases.
Thank you, Dr. Hamrah. And I'd like to ask if you could start your lecture, please.
Sure, we'd be happy to. All right, so I was asked to talk about the confocal microscopy and how that relates to dry eye after refractive surgery. In terms of refractive surgery, at least in the United States, there's roughly about 1 million cases done per year, about 670,000 LASIK cases, and the rest are surface ablation cases. The complications are known in terms of glare halos, haze, photophobia, dry eye, flap displacement, ectasia, and neuropathic pain and infection. I'm going to focus on the dry eye and the neuropathic pain in this case. So the recent dry eye workshop in 2017 redefined dry eye as a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film, accompanied with tear film instability and hyperosmolarity, which was known since the 1960s and 70s, ocular surface inflammation, which was added in the first dry eye workshop in 2007, and now also with the neurosensory abnormalities to play etiological roles. So what we basically have is 3 pillars of dry eye, which include the tear deficiency and evaporation, hyperosmolarity in the bottom. You can see ocular surface inflammation and neurosensory abnormalities, and all 3 can contribute to dry eye disease in these cases. This is a definition in terms of how the patients are being divided. There's a symptomatic and asymptomatic group, and the patients who are symptomatic, which I'm going to focus on today, can either have surface disease changes, which we see with different markers and biomarkers on the surface of the eye with slit lamp, etc. And the patients who we find little signs who have likely neuropathic pain. And then the dry eye itself is then divided between aqueous deficient, evaporative, or mixed type of diseases. The current ways we measure dry eye are several. You can look at the fluorescein tear breakup time, the non-invasive tear breakup time, osmolarity, corneal fluorescein staining, conjunctival staining, and redness, and Schirmer's testing. Now, the problem here is that while these are good ways to evaluate tear film deficiency and the surface desiccation, they do not allow us to kind of look at the 2 other pillars, meaning the inflammation and the neurosensory abnormalities, because whether you have inflammation or not, or neurosensory abnormalities or not, you can have all of these signs as well. So while these allow you to treat the ocular surface desiccation, they do not allow you to know how much of inflammation there is or how much of neurosensory abnormalities they are. If you look at division of different groups, and here you have in black the normals, in green mild, blue moderate, and red severe dry eyes, none of these current tests seem to be accurate, and so the reproducibility, when you actually look at day 0 and day 7, you repeat these tests in the same patients, seem to be very, very bad. So you have some very severe patient who you can reproduce, the normal ones are reproducible, but all these different dry severity groups are not reproducible. So we don't have a good way of actually repeating these tests in these patients and have good accuracy in these cases. So the limitation basically are that there's lack of sensitivity and specificity for tear breakup time. There's various grading systems for corneal and conjunctival staining. For Schirmer's, is a high variability and lack of level 1 evidence, and tear osmolarity studies have also shown very high variability in these cases. I'm going to first focus on what about the inflammatory component of dry eye disease after the refractive surgery as well. And we know from work from Flugfelder's and Dana labs that the surface desiccation results in activation of antigen-presenting cells, which then drive to the lymph node and activate T cells or lymphocytes, and they come back and damage the surface of the eye. through inflammation. We also know from work done a long time ago when I was a postdoc that there's actually a lot of bone marrow derived cells, including dendritic cells and macrophages present in the cornea. And so these get activated when you have surface desiccation and inflammatory markers. Now, luckily, over the last 10 years, we have now technology that can actually visualize the immune cells in the cornea live. And this can allow us to potentially measure the level of inflammation, which is important after a refractive surgery. I'm going to get to that in a few minutes for several reasons. The confocal microscopy has a 1 micron resolution in terms of the HRT3 or HRT2 with a raster cornea module, and it can basically capture layer by layer analysis of the cornea, and you can do optical sectioning or horizontal sectioning as well, depending on how you angle the patient. While the ConfoScan kind of shows some of the nerves, and this is the images on the same patient, the laser confocal microscope shows more nerves in the same patient and also shows these dendritic immune cells, which are markers of inflammation in these cases. Some levels are normal, but once you have beyond a certain level, this becomes abnormal. These immune cells are basically sitting at the subepithelial layer. The black on top is the tear film. Here you have the epithelium, and this is the Bowman's layer. And you can see they're sitting right over the Bowman's layer at the base of the epithelium in this case. They have various shapes, and that depends on the maturation levels. These smaller ones are basically immature cells and are basically present in normal corneas, and these larger ones are basically activated and are a sign of activation during inflammation in these cases. And these are basically confirmed when you do donor corneal stainings and these corneas later on as well. We have done studies looking whether snapshots of the cornea versus doing a whole collage are different in terms of density. So we actually did a 3 by 3 millimeter window in the cornea with a special software, and also looked at the single 400 times 400 micron, which is a typical picture you get, and compared the density between these two. And we can see that when you compare the small window to the whole large window, there was no significant difference in either main subbasal nerve density or dendritic cell density. And that therefore, if you have a small window in a non-infectious patient, for example, these will be found representative in this case. When you also look at the dendritic cell density between two observers, you can see we have a very good correlation in case they're trained observers. And when you look at the standard images compared to the composite images, we also get the same mean density of these cells. So there is really no difference whether we get several small pictures versus a large picture, which has always been a critical issue with the confocal, to kind of make sure that we actually get the same exact picture, but we don't need that because the overall changes in the cornea are representative in that. The other question is, are these dendritic cells that we see in the cornea actually a marker of inflammation? So we did a study a while ago where we compared the dendritic cell density by confocal to tear biomarkers in terms of inflammation. We looked at interleukin 1, interleukin 6, interleukin 8, and interleukin 17, and you can see the dendritic cell density on the x-axis correlates strongly to the cytokine protein levels on the y-axis significantly for all of these four, suggesting that these changes that we see in the cornea by these dendritic cell changes is a marker of the inflammation level in the ocular surface in general. So what we have right now is we have these cases that we see in general. Typically after LASIK, you can have some mild dry eye, the severe dry eye. So the one thing we don't know is there inflammation resolved after the initial taper with the steroid, which can be 2 to 4 weeks, depending on the physician's preference, or is the significant inflammation still remaining, which can basically result in continuation of dry eye. And so how do we treat these patients? Do we just give them artificial tears? Do we give them anti-inflammatory? Do we give them steroids, etc.? And the other issue is that the presence of inflammation can also then result in neuropathic pain because it can make the nerves more sensitive in these cases. So it's crucial to know that after the procedure and the taper, whether we actually have inflammation lingering in the eye or not. And we cannot see that by the ocular surface exam alone. We looked at the dendritic cells in a dry eye setting, and we saw that in the control, you have some dendritic cells, about 25 to 30 cells per millimeter square. In mild evaporative dry, there's some increase, which is significant. But when you have aqueous tear deficiency, which we also see after a refractive surgery procedures, there's significant inflammation up to tenfold increased in these cases as well. which is crucial. And when we look at the, when you break those down versus immunological and non-immunological, the patients who had underlying immunological conditions such as Sjogren's, celiac, graft versus host disease, these are the patients who actually are at higher risk. So when we do refractive surgery procedures with a patient who has an underlying immunological condition, we have to be more aware of that there can be increased inflammation even after the taper of the initial 2 to 4 weeks. We did a study then correlating the severity of dry eye disease to the dendritic cell changes that was published in July this year. And the question is, do they actually correlate with severity? Patients were divided based on the dry eye workshop criteria in stages 1 to 4. And this is based on symptoms and different sign levels here. And these are basically looking at 300 eyes of 150 patients with dry eye disease. We then looked at the dendritic cell density and the size as a marker for maturation of these cases between independent observers, and the groups were basically age and sex matched, and there was no statistical difference between age and sex in these cases. What we saw is that when you look at the dendritic cells here in a normal and grade 1, there's very little dendritic cells here. There's some increase here, but at grades 2 to 3 and 4, there's a significant increase in the number of dendritic cells and the size of the dendritic cells here, which correlated with the severity of dry eye disease. When you plot these, you can see that as early as grade 1, you have about the 3 to 4-fold increase in the dendritic cells, suggesting that even in the mildest stages of the dry eye that you see on the in terms of mild staining or mild tear breakup time, you already have increase of the inflammation present, which doesn't significantly increase further. So all of these, although there was different sizes of these, the density was already up in all of these cases. What was different was that the size of the cells was not significantly increased. So at grade 1, we have an infiltration of these immune cells, but they're not activated. So the level of inflammation is lower, versus when you look at this grades 2 to 4, that the size of these cells was increased, suggesting that these cells get more activated at later stages. So the other question is, can these be then assessed for looking whether your therapeutic efficacy, like let's say you start a patient on anti-inflammatories, can we actually measure a response with this device as well? So we did a randomized controlled trial, which included 54 patients divided in artificial tears, loteprednol with tobramycin, which is Lotemax, Xylet, and loteprednol alone, and compared the patients at baseline and 4 weeks after a twice-a-day application. Again, these groups were age and sex matched, and the number of patients were about 17 to 20 per group. So it was a small pilot study, but for imaging, you don't need as many patients as in larger clinical trial. These are the baseline data showing that the OSDI, which is a symptom score, tear breakup time, and the fluorescein staining score are very similar across all 3 groups, so it's comparable. And these are the dendritic cells as baseline, showing that all 3 groups that were elevated by about 5-fold to 6-fold between all 3 groups. Now, when you look at the before and after treatment, in the top row, you see the before treatment in all 3 groups. You can see there's increased the number of these dendritic cells. But post-treatment in the artificial tear group, there was no change or maybe even an increase. But in the groups that had steroids, we are able to resolve the inflammation with the steroid group to a significant level, showing that you can actually measure the changes in inflammation that you can't see on a slit lamp exam, because a lot of these changes are subclinical, and there's no markers for measuring inflammation in dry eye, and the redness is not really as accurate in this particular setting. When you quantify this, you can see that the artificial tear group didn't change, but the steroid groups decreased by 50% and 60% respectively. We then wanted to also see that, let's say, if you have a patient and you want to know, do they have inflammation or not, will this be different? Meaning that, can we stratify patients by having inflammation or not before even treating them, and will that have an impact on their outcome? So what we did here was a second multi-center, a second randomized trial, and these are basically patients in 18 and 20 per group. One group received steroid, the other group received no steroid, but what was different here was that there was an inclusion criteria that the patient had to have inflammation at baseline by confocal. And otherwise, these are basically have to have staining, lissamine green, and tear breakup time, but they had to have increased inflammation by confocal at baseline. Again, the groups were age and sex matched, which was fine. These are the baseline characteristics showing the tear breakup time, staining, and the dendritic cells were comparable, as well as the OSDI. And so what we see here again, similar to the other one, is that this is the delta from baseline. You can see there's about a 30 cell decrease with artificial tears at 2 weeks, and at 6 weeks, it was basically no difference. But with the steroid group, there was almost a 80% decrease in terms of the dendritic cell density at 2 weeks, and even a larger one at 6 weeks, showing that once you know which patient has inflammation or not, and then you treat the patient, you actually get even a bigger effect than randomly treating patients with steroids here. This was also reflected by change in the OSDI symptom score. With artificial tear, we didn't see any change in OSDI, but when we looked at the OSDI at baseline to 2 weeks and 6 weeks, there was a decrease by 15 points in both at both time points. What was dramatic was the changes in corneal fluorescein score. You can see with the artificial tears, there was a slight decrease, but we had about a 50% decrease with fluorescein staining score once we identified the patients who had inflammation and then treated them. So these data basically show that there's a correlation between the staining and the dendritic cell density, and they also show that dendritic cell density decreases with steroid use at both 2 weeks and 6 weeks in the steroid group, but not the artificial tear groups, and that there's a strong correlation between the staining and the fluorescein. And so enrichment of patients for inflammation using confocal prior to using steroids can give you even more effect, and that can be potentially applied to a refractive surgery patient. Once you do a taper, these could be scanned and see if there's inflammation present or not. And if you do have it, if you treat it, you get even a bigger effect, and you prevent long-term dry eye and other complications as well in these cases. The other issue I want to talk about is the neuropathic pain that develops after LASIK, which has become very to the forefront of clinical findings as well. And so all of us see that after procedures, there's classical dry presentation with out of proportion symptoms. The patients complain a lot, but we don't see much on exam. Patients have dry-like symptoms, but we don't see any signs at all. And there's just unexplained corneal pain after refractive surgery, and the epidemiology of which is unknown at this point. So these are potentially patients who are symptomatic and they have mild or no signs, and basically they could have neuropathic pain. We did describe in 2015 a series of cases with corneal neuralgia after LASIK. That was 5 years ago. And since then, we've done a lot of work in that area to understand this better and to treat this condition. There's different types of pain. There's nociceptive pain, which is pain caused by noxious stimuli, which you get right after refractive surgery or an abrasion. There's inflammatory pain, which patients have, which can be through persistent inflammation, and this is not neuropathic. So I've seen many cases after refractive surgery where the inflammation did not resolve. The patient has pain, and the treatment with anti-inflammatory just resolves the pain because it's just purely inflammatory. There's neuropathic pain, where you have peripheral nerve damage, which we get with any LASIK refractive procedure, that then results in chronic neuropathic nerve-related pain. We have non-inflammatory, non-neuropathic pain, where there's no tissue damage, just doesn't apply in this case. And then there's multiple of these, they can come at the same time. So it's not only exclusively present, there can be multiple cases at the same time. Neuropathic pain is caused by a lesion or disease of the somatosensory system. So the lesion in these cases are induced by refractive surgery or even cataract surgery. Symptoms can be enhanced pain perception or called hyperalgesia, allodynia, which is pain from non-noxious stimuli, photoallodynia, which is pain from light, or spontaneous pain without any clinical signs as well. And most of these patients do not respond to conventional dry eye treatments. The mechanisms are twofold mainly. You have damage in the nerves, which you get from refractive surgery, and you have pro-inflammatory mediators that have to be persistent. So the only way this can develop is the inflammation has not been controlled after surgery, and whether that goes away and comes back and rebounds after a few months, or whether that kind of is persistent after the taper is done. These are kind of the two factors that do result in neuropathic pain. Anything that causes nerve damage can result in neuropathic pain, whether it's an infection, a refractive surgery, contact lens, irradiation, chronic diseases, and trigeminal neuralgia. All of these can result in nerve damage and basically result in neuropathic pain. Here is a summary of cases we had 2,000 cases, 1,200 cases and broken down. And these are basically the type of diseases that we get. These different infectious cases, chronic dry eye, refractive surgery, cataract surgery, and then these chronic neurological or psychiatric systemic diseases, which can also result in this as well. If you look at the prevalence, you can see that the most common cause is actually refractive. If you look back by surgery, is cataract surgery in about 22% of cases, 15% from LASIK, and about 6% from PRK, and then any other surgery can cause it as well. Although interestingly, we did not see any cases after corneal transplantation yet. If you look at the systemic condition, as you can see, most of them are neurological or psychiatric, with migraines and fibromyalgia being the most common, anxiety, depression, neuralgia, and small fiber neuropathy being all the more common ones. So any of these are potential risk factors for patients to develop this condition after refractive surgery as well. And so if you have patients with these conditions, you should be more aware that this can happen. In terms of their symptoms, 65% have general pain, 30% are light sensitive, 8% have discomfort, and 5% are burning, but about 30% can have multiple, more than one of these symptoms. So what does pain mean to these patients? There's a decreased autonomy, there's decreased physical and social function, decreased enjoyment and quality of life, challenges to the dignity, and also threat and increased suffering, and some of them can be suicidal. And these can result in also physiological effects of the pain, including insomnia, anxiety, depression, elevated tachycardia, and blood pressure, etc. So this pain can have also a lot of systemic effects in these cases. We did publish a paper recently, a couple of months ago, comparing the characteristics of post-refractive surgery-related neuralgia to post-herpetic. And when comparing all the clinical findings, the pain level, the quality of life, confocal, all of these are very, very similar and were slightly higher than in the refractive cases than in the post-herpetic cases. And our conclusion was that neuropathic pain due to refractive surgery is actually similar in characteristics, if not higher, in terms of pain level, quality of life, and confocal findings compared to the neuropathic pain due to post-herpetic neuralgia, which is quite significant. And we all are familiar with that. Now, how do we diagnose and manage neuropathic pain? Here's where the confocal comes in, because it's difficult to differentiate the patient just from an exam. The way we typically approach is we have a patient who comes with pain and discomfort. They fill out questionnaires. We do functional testing, including a numbing drop to see whether it's centralized or not, do corneal sensation. We look at the ocular surface, rule out any other etiologies for discomfort, and do confocal microscopy. I'm going to get into that now. We also have a ocular pain assessment survey that's actually currently being validated in Portuguese by one of our collaborators right now. So it should be available in Portuguese as well soon, if it's not already available. And basically looks at the location of the pain, the acute pain in the last 24 hours in terms of the most, least, and the average, the pain in over the 2 weeks, the non-eye pain in the face and the head. It looks at quality of life changes, what's aggravating the pain, what's associated with the pain, and how much relief the patient has. So by the time you see the patient, all of these are already filled out. So you have a good idea of how the patients are in terms of baseline and how they've changed over time, because most patients with pain can't remember how their pain was. It's very difficult for them to remember. We typically do a hyperosmolar saline test, which is the 5% sodium chloride. This results in activations of polymodal nociceptors. And we will wait 20 seconds. And typically patients who have hyperalgesia, they get an increased level of discomfort by 2 points or more after 20 seconds, which then resolves after about a minute or two. And this is one of the ways we can actually test for hyperalgesia right now. The other thing that happens in these cases, when you have nerve damage and you have persistent inflammation, these nerves do not regenerate normally. So what you get is these microneuromas that are these abnormal regeneration of the nerves in terms of the end bulbs. And then you have the area that's denervated, and then the reactive sprouts and the healthy nerves try to cover that area. So you have more nerves here. And this results in allodynia from the microneuroma and hyperalgesia from the other area. Interestingly, this can be observed on confocal microscopy. When you compare two neuromas on the skin, we actually can see these microneuromas on confocal microscopy, and which is kind of suggestive of neuropathic pain. And we don't typically see that in other conditions, although to smaller levels. The picture that they showed in the previous talk, that was labeled as microneuroma was actually not a microneuroma. There was actually an entry point from the stromal nerve into the epithelium. Microneuromas are actually much larger and more reflective. And here kind of some typical pictures that you would see, which look different than the one they showed. We published a paper a month ago showing that visualization of neuroma by confocal microscopy could be an objective biomarker for neuropathic pain. This may be helpful after refractive surgery as well. And we did the pilot study, and we have done more studies now, but the pilot study had 16 control eyes, 19 dry eyes, and 20 neuropathic pain patients. And the inclusion criteria were the patient with dry eye had all the typical dry surface changes, but they had no pain, and the group with the neuropathic pain had the pain but had none of the other markers, so basically a completely normal eye exam. And what we found was when you look at the age and sex matching, the age and sex were kind of comparable. When we looked at the dendritic cells, they were increased in both dry and neuropathic pain, but the difference was not significant here. So while we have an increase in both of these conditions, it was not different. And the patient who had higher level of inflammation with dry eye, when we looked at the nerve density and morphology, we could see that in the dry, there was a decreased nerve density compared to the control. But again, in the neuropathic pain group, we have these large microneuromas, which is these terminal dilated end bulbs that are very irregular at the end. And typically the nerve itself looks reflective as well in these cases. So when you look at the quantification of the nerves in terms of comparing the control dry, there was beating in all of these. The nerve density was decreased in the dry and neuropathic pain group, although it was lower in the neuropathic pain group. And what we saw that was different was that none of the dry patients had neuromas versus all of the neuropathic pain had microneuromas. And so while the nerve density is decreased in both of these, both the nerve density and dendritic cells are comparable between the groups. And in this case, we found that microneuromas was observed only in the patients with neuropathic pain, but not the dry patient. So we had a higher sensitivity and specificity. Neuropathic pain is not the same in terms of all patients. It can be peripheral or central. Some patients have central even before. Some patients will have peripheral neuropathic pain and it's not treated and kind of misdiagnosed as dry eye, and that becomes chronic, can develop centralization, meaning that the pain can actually be triggered like a phantom pain, like after amputees develop that as well. One of the things that can be differentiated is with the proparacaine or numbing drop that can be used. You have to wait about 90 seconds, and when the pain level comes down to 0, it's all peripheral. If the pain doesn't change at all, it's basically likely centralized. I mean, the pain improves, but it's still persistent, meaning goes from like a 7 to a 3, and it's likely a mixed type of pain. And the way that's important is because that has an impact in terms of how we treat these patients. In terms of peripheral, we usually use regenerative type treatment with autologous serum tears, which has neurotrophic factors or amniotic membranes. Here's a study where we use confocal microscopy to look at the pre-treatment changes in terms of 3 patients. And after serum tears, autologous serum tears, it was increased and the pain decreased here. You can see that the pain that was about 8 to 10 decreased to about 1 to 6 within 3 months. And this correlated with the regeneration of corneal nerves in these cases. We also looked at amniotic membrane and applied the amniotic membrane in these cases. And we again saw that all patients within a week had significant decrease of pain from about average of 6 down to 2. And some of these cases cannot tolerate the membrane long enough. And even in those cases, when we had to take the membrane on within 2 or 3 days, they had improvement in pain in 60% as well. And so here, those are a couple of options. So in general, the way we approach these patients is if they have peripheral pain, we use this neuroregenerative therapy with anti-inflammatory. The anti-inflammatory is important to prevent the resensitization of the nerves. So although they get better, they can get worse again. So it's very critical that you use anti-inflammatory therapy chronically in these cases. We also treat the surface. When there's mixed, we do that plus pharmacotherapy. So if the pain doesn't go down to 0 and it's about a 3 or higher, I would suggest using pharmacotherapy right away rather than waiting. And you can also use some complementary therapies like acupuncture, cardio exercise, dietary changes, stress reduction. And if the discomfort doesn't change whatsoever, then I think the focus should be on the more systemic type of pharmacotherapy in these cases. A couple of last slides on what we use therapeutically. We use serum tears. I know it's been difficult to get in Brazil right now, which has neurotrophic factors. which level helps with the injured nerves and epithelium. There's a lot of data on that. We use corticosteroids like soft steroids to keep the inflammation at bay, to prevent resensitization. We use amniotic membranes, bandage contact lenses temporarily to kind of decrease the hyperalgesia, and then additional surface treatments. And in terms of pharmacotherapy, we use nortriptyline. We just published a paper on that 2 weeks ago, showing there's up to 60% efficacy in decreasing the pain by 50% or more. Carbamazepine, low-dose naltrexone, which are both about 50% effective, tramadol, and then later on gabapentin, etc., which work good for diabetic neuropathy or keratopathy, but not for these post-LASIK cases in these cases as well. These patients should be treated early. We can't rely on slit-lamp exam alone. If there's suspicion, confocal microscopy can help with diagnosis, and the combination therapy works faster, and the patient needs to be assured. So in summary, I think confocal microscopy is a beneficial tool to image the cornea for evaluation of inflammation and the neuropathic pain. We are working on artificial intelligence right now to basically improve the assessment of that, because that's one of the critical issues that's there. And we should have soon artificial intelligence software available to actually have a fully automated way of analyzing these confocal images for implementation in the clinic, which would be easier. I would like to acknowledge the members who are involved in this particular projects that I just showed in the clinic, and also the rest of the lab. And thank you for your attention and the funding resources. Thank you much.
Thank you very much, Dr. Hamrah. And I'll open here for questions and comments. I was thinking when you stated that about the inter-observer difference between the examinations, and if AI could help in it, but you have addressed it on your last slide. Could you comment a little bit more? How are we into the AI and in vivo confocal microscopy?
So there's a couple of groups that have come down with when they select the images, they have a software that can measure everything. We have a fully automated software that can now get the whole confocal images. If it's hundreds of thousands by patient, it goes through it. It understands which layer is which. It separates the epithelium, nerves, stroma, and endothelium. It can evaluate all the layers within seconds, fully automated now. And it also detects the microneuromas separately at the same time. So you have basically a way to getting immediately the results in terms of the nerve density, the dendritic changes, epithelial, endothelial, and also whether they have neuromas or not. And so I've been working on that for the last 4 years right now.
That software that you just mentioned, there has been, if I'm not mistaken, a validation study from Meta, Meta. That is the same software, right?
No, it's a different software. They only looked at the software to look at the nerve changes, but they have to kind of select the pictures. So somebody has to pick the picture. So they look only at single pictures. This software that we do, it actually goes through all images automatically. So there's no human involvement in that case. Yeah, there's 3 other groups who have done softwares like that, where it basically traces them. So instead of doing semi-automated tracing, it's fully automated tracing. No, that's different.
Well, that's great. Congratulations. And Dr. Leraci has asked here, in your practice, have you seen many patients with neuropathic pain after refractive or cataract surgery?
I showed you the data. It was about 20% of my patients are cataract surgery and about 15% LASIK, 6% PRK. And I see about 200 new patients each year. We have about 1,200 patients right now that we've seen. So you can do the math about of the 1,200, 1/5 are cataract cases, and about 15%, which will be 150 to 200 cases, are post-refractive cases right now. So we see about, I would say, 30 to 40 new patients each year after refractive surgery who come with neuropathic pain.
Okay, and Dr. João also asked, how often should we repeat confocal microscopy in these cases of neuropathic pain patients?
So I typically do it the first time only for diagnostic purposes. When they get better, I maybe repeat it every 3 or 6 months. The main reason is not for me, it's for the patients to actually get some positive feedback loop to see, oh, what I'm doing is working. And the patient kind of get focused as this, so long as they see there's an improvement in something that's damaged, it has a psychological effect on them as well. I don't think that as long as the patient is improving, you need to repeat it. The only reason would be to see whether the inflammation can flare up, which is important because you may get benefit, but when the inflammation flares up and you don't know about it, then it can kind of set you back. So I usually repeat it only if the patient gets worse again. But I also repeat it for some patients who need it psychologically in this case.
That's great. Our specialists, Dr. Paula and Dr. Thais, would you like to comment or do you have any questions?
Dr. Hamrah, when do you consider using oral medications in these cases? It's only if you see it's a centralized pain, or if you taper like steroids and patient still refers pain, but you don't really sure it is centralized, you still use oral medications?
So yeah, if it's centralized at a high level, let's say after the numbing drop, the pain is about 3, 4, 5 or higher, then I suggest it to the patient. Some patients don't want to do it, which is fine. If it's less than that, I'll wait first to see how the topical gets better. Now, the other case scenario where I use it is in case of non-centralized, if the pain level of the patient is very high, and we know that there is no immediate relief with serum or anything else. And so because serum tears can take about a month to start working, and the patient is like very distressed, potentially suicidal, has pain levels of 7, 8 or higher, then I could sometimes selectively use it as well to get the pain down right away, because these oral medications work within weeks and to a dramatic level to about 50 or 60% decrease in the pain. And so then I use it as well temporarily, similar to what we do after post-herpetic neuralgia as well. So.
Great. So if you don't have any further questions, I would ask for Dr. Paula to start her case presentation. And also thank you very, very much, Dr. Paula, for your participation in this meeting. Dr. Paula Kataguiri, she has her med school and ophthalmological residency in ABC, and also her cornea specialization. And she has been a research fellow at Tufts University. That's where she had contact with Dr. Pedram Hamrah. And she's also a voluntary faculty at our refractive surgery service. And thank you once again for your participation, please. Paul, if you could share your screen.
Thank you, Taguchi. Thank you, Professor Wallace, Dr. Maria Cristina, for the opportunity to participate. Dr. Walton, thank you for helping me to go to Boston. And I had a really good time there. So I'm going to show this case.
And also, Dr. Hamrah, you've stated that neuropathic pain is such a problem. There has been a anti-LASIK movement some time ago in the USA, right? That has even reached the FDA and that motivated their patient outcomes-based studies a while ago, right? Do you think these episodes are the reason for that are associated with neuropathic pain after surgery?
I do think so, and I think we can potentially screen the patients out before surgery, hopefully. We're working on blood tests that can identify the patients at risk right now. And we're presenting some of our data this year. And I'm hoping that in a few years, we can actually have serology that can identify out the high-risk patients, because it's not a common condition. It's only happening in very few cases, but they're very unfortunate because they actually commit suicide. And I've lost 2 of my own patients. But I think hopefully we can screen these out with some blood testing to look at, they have some systemic underlying conditions that put them at higher risk than other patients.
Thank you, and sorry, Paula, for the interruption. Please go ahead.
So I'm going to present a case of a female patient, 73 years old. She came to the clinic recently saying her vision is fine, but complaining of ocular pain in both eyes in the last 6-7 months. She refers no comorbidities and she used only Zolpidem to sleep. And as ocular history, she had cataract surgery 1 year ago in both eyes, and she usually uses lubricant drops. At examination, she presented 20/25 corrected visual acuity, IOP is 14, and biomicroscopy and fundoscopy are normal. I'm going to show you pictures. So this is the external aspect of both eyes. We can see a mild blepharitis. And at a slit lamp examination demonstrates clear conjunctiva, clear cornea, IOL is well positioned and anterior chamber is deep, and there is no fluorescein staining. Fundus examination is normal with pink optic nerve, macula is normal, and retina is attached. Besides, she completed a OSDI questionnaire. The score was 41. Tear breakup time was 8 seconds, and shimmer test was within normal limits. Dr. Hamrah comment on the OPAS questionnaire. It's not available in Portuguese yet, but I know it's coming. So as she has minimal clinical signs on clinical examination, we have decided to do a corneal confocal microscopy scanning on her. I have used HR33 from Heidelberg, and to perform the procedure, both eyes were topically anesthetized, and then we mounted the cornea module with a disposable cap, and then we manually advanced the equipment until the cap touched the surface of the cornea. Dr. Hamrah already showed some picture in his lecture, but I brought here some images from the normal cornea just to show how we can see all cornea layers by in vivo confocal microscopy. So frame A is the superficial epithelial cells, B and C is the basal epithelial cells, G is the subbasal nerve plexus, and E and F is the keratocytes, and H is the endothelium. So IVSM images from the right eye show normal epithelial cells. Subbasal nerve plexus demonstrated increased nerve tortuosity, anomalous nerve ending, and the presence of neuroma and beading. Stroma and endothelium have no alterations in the right eye. And looking at IVSM images from the left eye, epithelial cells are also normal. And again, subbasal nerve plexus from her left eye show increased nerve tortuosity, decreased nerve density, and increased number of inflammatory cells. And we also see the presence of neuroma and beading as well. And stroma and endothelium of the left eye is also normal. So considering she presents symptoms of ocular pain, minimal clinical signs, and evidence of nerves injury by in vivo confocal microscopy, I think we can hypothesize that she has neuropathic corneal pain due to previous dry eye syndrome, and it also can be related to the surgical procedure she had. The patient continued using lubricants and doing hygiene. She started steroid drops in a low dose recently, but she couldn't come back yet to the clinic to repeat the exam. But I could talk to her on the phone and she feels slightly better. And I would ask, and I would would ask Dr. Hamrah if would you start autologous serum tears in this case concurrent to anti-inflammatory drops, or would you wait some weeks? Could you comment on this, please?
So what I usually do is I start the serum tears with the anti-inflammatory therapy together.
Okay.
If there's no nerve abnormalities, I try anti-inflammatories alone. But in this case, since you're having bilateral nerve abnormalities that are suspicious, I use them at the same time. The serum tears on its own doesn't work as well either, because it gives temporary improvement, but then the inflammation makes them more sensitive. So it's important to have the anti-inflammatory therapy always with the serum. And so without the serum, you don't have an improvement in the nerve function either. So you only treat the inflammation, which gives them sometimes a slight improvement because the inflammatory environment has a negative impact on the symptoms, but not to a dramatic level. So unless you use them together, we did a trial comparing each of them single and together, you don't get the big benefit here. And the oral medication depends. I didn't see how much she improved with numbing drops.
Yeah, I didn't test it yet, but since she come back, I can try.
Yeah, it's easy test.
Yes, it is. So thank you, Dr. Hamrah.
You're welcome. And the way I use the anti-inflammatories, I use a taper. I start at 4 times a day for 2 weeks, twice a day for 2 weeks, once a day, and then I go to like twice a week or so to prevent flare-ups. I didn't find that cyclosporine or lifitegrast have the similar effect. So unfortunately, we kind of stuck with like loteprednol or something similar that's safe. Sometimes high dose cyclosporine does help, but that's like at 1 or 2%, not at the level of 0.05% or 0.1%.
Dr. Hamrah?
Yes.
Thank you very much for your brilliant presentation. It's Thais. He told me, I just want to do some questions. You said that you have a program that you can count all the cells, the nerves. It's a great software. But considering that we have to capture different places from the cornea, for example, to measure the dendritic cells, we need to capture, maybe it's important to capture images from the center and the periphery, because from my work, I realized that there is difference in the dendritic cells concentrations between the center and the periphery. How is the way that you capture your images?
So I think that, first of all, you're right. There's differences in gradients in periphery and center. I didn't show, we have a lot of data on that, but I didn't want to show that because of time limitations. In the end, you have to compare apples to apples. So that software can do all the areas, but you also need normative data. So we have developed a normative database over the last decade where we have like hundreds of patients from normal eyes. So we have different regions. So we have all quadrants and the center now. And so you can use the one thing that is two things. One, the peripheral cornea always has inflammatory cells even in normal patients. That's known. And so the increase that you measure from presence to increase is harder to measure in terms of inflammation. The changes are easier to detect in the center. There are significant changes in all regions. So I think that to get to the level of inflammation in a chronic disease such as like dry eye, we don't need all the regions really, because when we did the collage and we did the peripheral studies, the center and the peripheral measurements correlated strongly. But one could use a peripheral area, but then you also have to compare it to peripheral numbers in normal subjects.
Okay, thank you so much. I'm sorry, I couldn't catch all your presentation.
That's all right.
But thank you so much. It was great.
Thank you, Thais, and thank you, Paula. Dr. Hamrah here, and Dr. Leonardo is pointing out that in Brazil, unfortunately, we don't have autologous serum available easily. So you have already commented on that, but is it possible to use anti-inflammatory drugs and oral medications, and which one do you start with? You have pointed out when commentating the Dr. Paula case, but if you could state it once again.
So I think if you don't have access to anything, you can treat these patients like any other small fiber neuropathy. There's length and non-length dependent small fiber neuropathy, and there's oral medications of that. So if the patient is comes with hand pain or facial pain or mouth pain or leg pain or eye pain, it's basically the same thing. We can use any oral medication to suppress the symptoms, although the disease will not be reversed. And typically my number one choice is nortriptyline in patients under 75. Otherwise it's low dose naltrexone. The third option is a combination of low dose nortriptyline with no dose naltrexone. And then I go to the other ones I mentioned, which we have also in that paper. Then the anti-inflammatory can help a little bit. But then again, that would have to be used probably with oral medications. Alternatives to serum would be platelet-rich plasma, PRP. There could be amniotic membrane fluid. So all of these are also having the neurotrophic functions, which potentially can also be used instead of autologous serum tears. The last one is a finger prick. Patients can finger prick their own finger and touch the eyes, and that's been shown by some groups in England as well. So anything that has more neurotrophic components to it could help the patients, although the finger prick is difficult to use chronically because you have to do it multiple times.
Thank you. Any other comments or questions? We are just starting, I think, at least in the refractive surgery sector, because Dr. Thais has already some very nice work with confocal microscopy, because we've just received, kind of just because there has been us, I think, more than a year ago, we received the Heidelberg corneal tomograph with the confocal microscopy module. And so we are starting to understand confocal microscopy a little better, especially when for our sector in refractive surgery and cataract surgery. So I would ask you, Dr. Hamrah, do you have any tips on how do we do these baby steps, I mean, in our clinical practice? You've mentioned a lot of indications and patients, but do you have any tips for starting to do these examinations at a regular basis, and how do you incorporate that in a service? Because you work with it, so I think there is a huge bias, because every patient will have to do these examinations. But how would you suggest to incorporate it in our service?
So I think a couple of points. One, I would get a joystick for it. There's a joystick that the inventor in Germany makes. It costs €1,000, but it will speed up your scanning time by 4 or 5 times. And so right now, for us to scan a patient takes 5 minutes. So it's kind of almost the level of OCT. Without the joystick, it's very difficult because you have to use the 2 hands and a foot, and it's kind of difficult. And so I would get the joystick, with Heidelberg doesn't sell, but you can get that directly from Professor Stave in Rostock. The second is to actually have at least 2 people who are trained in it and have dedicated personnel for the training. It is easy to do as a single person. If you have the staff available, if 2 people do it at the same time, one is kind of looking at the patient and adjusting, and one is driving the joystick and scanning, it would speed up the time even further. Without everything, it's complicated. It takes 20 to 30 minutes, so it's hard to implement it in practice. I have a presentation of how to do the implementation. And then the third part is to actually have train the people to actually be able to recognize what is important, and they can pre-scan and print the pictures out on a chart. So all you have to do is just look at the pictures like in OCT and know what's happening, because it's difficult for the physician who's busy to go through all the pictures and identify things. I do it still myself in case of like acanthamoeba or fungal keratitis, if it's not a clear evidence, just to not miss anything. But I think for these purposes, if you do these mini steps, you can get easily implemented in clinic, and will only decrease about 5 to 7 minutes of scanning time for a patient for both eyes, which is not unreasonable, I think.
Thank you very much for your suggestions, Dr. Hamrah. And here, Dr. Denise, thank you for joining us in our meeting. And please feel free to talk if you wish.
Good morning, Pedram. I just want to thank you for coming to our meeting. It's an honor to have you here. I do believe you are the best one in confocal microscopy in the world. Thank you so much. And I hope you and your family are doing well in this crazy time of a pandemic. And I have a question for you, Pedram, of course. Not acanthamoeba, although you know I do like to study acanthamoeba. And I'm just wondering, because unfortunately I missed your talk because I had a very early meeting this morning, a surprise meeting. But anyhow, I regret I couldn't see your talk. But I'm wondering, because you talk about dry eye, about any study on confocal microscopy and neuropathic pain in dry eye, because this is so new and so difficult. It seems that just because we started to talk about, the patients start to appear. So what do you think, Pedram? And again, thank you so much, and an honor to have you here.
Thank you, Denise. It was kind words. I actually spent half the time on neuropathic pain. Was 50% on dry, 50% neuropathic pain. But yes, you're right. I mean, you find what you look for. So if you look for them, you find them. And if you find them, they'll find you eventually. So you get even more. But yeah, I think it's a very important step, and it's difficult to diagnose by slit lamp. And I went to the whole algorithm of what we find on confocal, how we can treat these patients. And I'm happy to forward you the presentation as well.
Okay, and Pedram, be sure that we are going to invite you to talk in the cornea section about acanthamoeba keratitis, okay? Thank you so much. Again, very nice to see you. Stay safe, okay?
As well, Denise.
Bye.
And Dr. Denise, this lecture will be, we can make it available for you.
Oh, that's wonderful. It is true. Thank you so much.
Thank you for your participation, Dr. Denise. And well, do you have any other comments or questions? If not, I will kindly once again thank for great presentations that we've had today. Dr. Hamrah, of course, you're an excellent, brilliant researcher, and also very masterful managing these cases. And thank you very much for sharing your experience and these suggestions that will certainly make our lives easier here with our new equipments. And thank you once again for sharing your time and knowledge with us, and also Paula for making this contact and also presenting this beautiful case in our meeting. Thank you once again for our attendees as well. And as I've just stated, for those who missed it, it can be watched later on YouTube and our department channel. I'd like to wish everyone a nice week and a nice weekend. And for the next meeting, we'll hold a session on pseudo exfoliation and cataract. So we're back to cataract once again. And thanks, everyone. Have a nice day. Dr. Pedram and Dr. Paula, feel free to make your final remarks as well.
Thank you. It's been a pleasure and honor. It was very exciting to participate in this meeting. Thank you very much for the invitation.
So thank you again, Dr. Hamrah. Thank you, Taguchi, for organize everything. And I hope we can meet soon, Dr. Hamrah, since
yeah, I hope so too. Thank you.
Pandemic allows us to go, right?
Of course, of course.
Actually, Paula, Pedram, has been of a very good help to us with confocal microscopy. I remember a long time ago, you told me, pay attention in Paula, she's very good. And you were totally right. She's wonderful, wonderful in Acanthamiba for me. She's helping me. And Paula, thank you so much. I wanna say this in public, okay? Thanks, Pedram, for the tip about Paula.
Yeah, she's brilliant and kind, which is important.
Yes, it is true.
Thank you, Dr. Denise.